I'm not going to read through your full bio here, but very distinguished, has lots and lots of experience in this area. And I will turn it over to Laura. And if you want to do kind of an introduction of yourself, and I'm going to actually switch over to Laura's slides. So forgive me as if you need to close your eyes as I'm closing things down and opening up a new slide, because I know that can be a little bit jarring. Please feel free to do so.
All right. Thank you for setting all of this up, Jessica. And I'm very, very excited to get to do this. So I'll just give you guys a little bit of my background and information while we're getting the slides up. So the reason I'm really excited to do this is that my background is in mental health. And I have a private practice. I've been doing that for, oh my gosh, you guys, a long time. As the years go by, it just sounds longer and longer to me. So a super long time. And if you guys are thinking, wow, she looks very youthful, you are correct. So we'll just say I started when I was like 10. So I've been in private practice since 1998, and my areas of specialty have always been trauma and grief and loss. And then back in 2009, which also now is sounding like a long time ago, I got an opportunity with the person who's now actually my consulting and business partner to work for the state of Ohio up at the Department of Developmental Disabilities. And I was a liaison between the Department of DD and the Ohio Department of Mental Health. Most states actually have those combined into some sort of behavioral health. Ohio is one of the few that does not. So I got an opportunity to learn this whole new world. And the reason that I was both excited and a little nervous about it is that those of you who come to us from a DD background or who work in the DD area, I can tell you, and I share the story with audiences, and I always say that this is something I'm not proud of. But the truth is that in my career in mental health, I also worked in agencies. My area was teenagers. I don't know if I have any teenager folks with us today. I feel like teenagers are really special people. They're sort of the pineapple on pizza of human beings. Like, they seem to divide people very quickly. It's either your jam or it isn't. And I'm one of those people that really enjoys teenagers. So that was my background working in agencies. And I'd worked part-time and then went back to school and got a degree and then got more stuff and eventually became a clinical director where I was working. And here's the thing that I start out with audiences that certainly won't make me sound very good. And that is that if any of you working in DD had tried to refer one of your folks to my agency for psychotherapy, I would have turned you away. And I would not have done that to be mean or to withhold anything from anyone, but because I would have told you that doing any kind of like psychotherapy with someone with a developmental disability, I didn't know how to do that. And I assumed that it required some kind of special training or magic toolkit to do this. So when I, much later in my career, sort of unexpectedly, had this chance to have sort of a foot in those two worlds, that we'll now call dual diagnosis, which is the term that NAD uses, of course. That dual diagnosis world of mental health and DD, I knew that I didn't know anything. And in the course of having that job, I got a chance to see videotapes of psychotherapists who had the same background as me, who were doing sessions with people with developmental disabilities. And I thought, here's my moment. Here's where I'm going to find out what that magic toolkit is that I didn't have and that my staff didn't have. So I watched these sessions about the ones that I remember the most were working with a gentleman who had lost both his parents within a year and had moved into a group home for the first time. And in the interest of time, I won't take you guys all through that, but I'll just say that as I watched this session, what struck me really hard was that this was a grief and loss session. And this is something that I've been doing in private practice and in agency work for years now. And what I saw in that moment wouldn't surprise any of you, but it surprised me. And that was that as the therapist made very common sense accommodations, right? She had, the sessions weren't quite as long and they were a little more concrete, but she was just doing a good job reaching him as a good therapist does with anyone that they work with, right? Meeting where he was. What I experienced that day as I watched that video was that a broken heart is a broken heart. And that all the things he was talking about, all the things that he was grappling with, had far more to do with grief than they did about having a disability. That came up occasionally, but that really wasn't what he was there to talk about. And in fact, he said something that has stuck with me to this day. And we're now, heading towards, 13, 15 years ago. And what he said was, I feel like my heart is broken inside my body. And if you've ever worked with grief or if you've experienced this for yourself, if you can think of a better way to describe that experience, I would love to hear it, right? So having a disability, having different ways that he communicated and different modifications that this therapist made really were not the point. The point was he was dealing with feeling like his heart was broken inside his body. And that was really the moment for me that I understood in a new, profound way that when we're talking about any given population, and I believe this is true, whether you're talking about kids or combat veterans or survivors of domestic violence or people with a developmental disability, there are some specifics that are helpful to know and learn about. So if any of you in the audience were working for the very first time with someone with a developmental disability, let's say in psychotherapy, there would be some things to learn about that culture and that world and how services are provided. I don't want to minimize those differences, but I do want to say that I think they are, on the whole, pretty superficial. And that when we talk about trauma, now we're shifting from talking about broken hearts. Now we're talking about frightened brains. And we don't have enough research in this area when it comes to dual diagnosis. We are getting more than we've had historically, and I hope that will continue. But I've yet to see any research that suggests that there's any substantial difference in living with a frightened brain, whether you are neurotypical or neurodiverse or what your executive functioning is or whatever. Some of those things may create complications. I tend to think that they create more problems in terms of how other people understand and support you than they do fundamentally in what it's like to deal with trauma. So I start with that because we are not going to be talking about developmental disabilities and trauma as if it's some completely different, unknown thing. If you have a good grounding in trauma, just like if you have a good grounding in psychotherapy and how to be responsive to someone that you're working with, then that's the heart of it right there. And there are always new things to learn and new ways to figure out how to meet your clients where they are. But human beings share much, 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 much more than they don't, right? So that's how I approach this. I always think it's helpful to begin with that. So that's how we're going to spend our time today. I will be talking about trauma. I'll try to talk about the things I think are the most important to grasp about what trauma is. We're not going to spend a ton of time on diagnostic things and definitions. That's part of a larger training that I do. We're not going to get into a lot of trauma therapy because that, again, is part of a bigger day than we have in our short time together. But what I'll do is take you guys through what I think is really the heart of understanding trauma. And then we'll open it up for questions and discussion, and we can be really casual about that. So, if you raise your hand, I'll try to stop if you have a question. I'm not great at the technology. So Jessica may be able to help me with that as well. And I'd love to hear from you guys what your experience and what your insights are as well. So we'll just keep this really loose and relaxed. I was talking with Jessica before we got started that I did create a sort of a digested version of the slides as handouts, and I can apparently put them in the chat area at some point when we're done, or I'll email them to Jessica. We'll figure it out. So if this is something that you're interested in, this is a way for you to have that when we're done talking today. But I kind of like to just start with everyone being present, which is why I didn't send them out ahead of time, just allowing you to not be multitasking and not looking through them while I'm talking. I want to reassure you that you'll have them, but I really want us all to just be here. Another way that you can learn more, and my business partner is always reminding me to do this, is that we did publish a book. I published a book about trauma through NAD Press. NAD, of course, is National Association for People with Dual Diagnosis. And if you go to their website or Amazon, you can find it. So that's another place where there's a longer conversation about these things. And now I have plugged the book. So in case, if Kevin asks, everybody just say like that I made sure to say something. Okay, so now we're going to jump ahead into it. And Jessica, if you want to get us through to we can go past that slide. Nobody cares about that. Okay, great. So we're going to talk very briefly about this. Tamsin Cottis may be a name that you're familiar with. She may not. She's actually a psychotherapist and a writer in London, England. And she wrote a book about running a mental health clinic just for people with developmental disabilities, which I always personally find amazing. Like, I don't know about Oregon, but if there were anywhere in Ohio that you could bring a client with dual diagnosis and that's all they did, that would be pretty amazing. Anyway, so this was her experience doing this. She wrote in her wonderful book, it is worth noting at this point that many patients referred to her clinic seem to have become disabled more by their traumatic life experience than by any congenital impairment. So just let that sink in for a second. I don't want to rush through that. She is saying that the people who came to her clinic for mental health assessment and treatment had more problems day to day, more obstacles to overcome by how they had been treated in life, almost exclusively at the hands of other people, right? Very few of them were in like mine cave-ins or something like that. More difficulty from that than from the Fragile X or the Angelmans or the Down syndrome or the whatever that they had been born with. And I think that if we were really going to take this to heart, so many of the services that states all over the country provide would really be turned on their head, wouldn't they? That if I'm working with you, I'm an individual that you're going to serve in your county or your department or your provider, whatever, that knowing my traumatic history, if that's something that's knowable, if you have access to that, knowing what makes me feel safe, knowing what makes me feel frightened, knowing what happens when I am dysregulated by some kind of trigger, that is where you start with your assessment and your planning and your staffing for me, not all the other stuff. And that's not to say that those other things like IQ or executive functioning or what syndrome I was born with, that's not to say that that information isn't important. It's just to say if we centered trauma, I believe we would be closer to meeting what people are actually struggling with, many of them. So I always start with this quote because I think it's such a radical statement for our field. We can go to the next one. Okay. Yeah, this is a good one. And I have so little time with you guys. I'm going to try to say this very quickly. So if any of you have any background with trauma, if you work with trauma, if you have trauma training, if it's simply an interest of yours, you probably know this name. Bessel van der Kolk is probably the most recognized name in the world for trauma. And in fact, when I taught graduate school at Ohio State in the MSW program, I taught trauma as one of my courses, and I made his book one of the textbooks that we used. So The Body Keeps the Score is incredibly well known, and I also recommend it when I'm doing trauma therapy with a client in my practice. I think it is one of the best books we have right now in summing up what we think we know and understand about trauma at this point and where the field is going in terms of trauma research and trauma therapy. So that's Bessel van der Kolk. And he said something in a training that I attended that for me really summed up what the problem of trauma is. Okay. So we'll go through this. There's a lot in a deceptively short paragraph here. He said, in fact, the past is the past, and the only thing that matters is what happens right now. And what is trauma is the residue that a past event leaves in your own sensory experiences in your body. And it's not that event out there that becomes intolerable, but the physical sensations with which you live that become intolerable. And you will do anything to make them go away. Now, one of the things that I think we have to start with here is when he says the past is the past. And the problem with trauma is not about what happened in the past. It's about what's happening right now. And why is this so important? Well, again, if you've worked with trauma, or if you've known people in your life, in your personal life with trauma, or if it's something perhaps that you've grappled with, you know that there's this very well-meaning but fundamental misunderstanding where people say some version of, well, how about if you just don't think about it? Or maybe you should stop dwelling on it. Or why don't you just try to forget about it? Right? In other words, thinking, well, it's just this troublesome memory, and if you just don't think about that memory, then it'll be fine. And if you've ever grappled with trauma, it's sort of like, oh, I should just not think about it. I wish I'd thought of that, right? If it were that simple, none of us would be here doing this training. Trauma would not be the problem that it is for people. And I think that while that can happen to anyone, and I certainly have lots of neurotypical clients who tell me versions of that story, I think having a developmental disability makes it even more prevalent. Because we seem to think, many of us, that if you have a developmental disability, things just don't affect you as deeply. And we know, in fact, that in many cases, it's actually the opposite. I won't go into that. But when I do trainings about grief and developmental disabilities, which is another area of passion for me, I tell the story of doing a webinar, actually, and a fairly high-ranking mental health professional with an advanced degree talked about a gentleman that they were working with who'd lost his father 7 months earlier. This gentleman was on the autism spectrum, didn't use spoken language, but was clearly very distressed and agitated. And the question this person asked me, my hand to God, was, when will he forget about his dad? And you know, not to be snarky, not to be sarcastic, I literally was dumbstruck and couldn't grasp how to even begin to answer that. So what I ended up saying was, well, I don't know. When would you forget about your dad? And again, my point was not to be jerky about it, but just to say, like, why would you think this would be less important to this human being than it would be to you, right? So, but there is this thing that happens sometimes if you have a dual diagnosis, where the answer all too often in a behavior plan or in a staffing is, well, just redirect Lara away from it. And this is not to critique behavior approaches. It's just to say that all too often, I think what that boils down to is, well, just distract her until she forgets about it. Again, if trauma were simply about the past, maybe that would work, but that's not what trauma is. The problem with trauma is that it has, especially in severe situations when trauma has been either early in life or severe or chronic or all three, kind of the terrible trifecta of trauma, then it has repatterned my nervous system and my brain. And it's the result of that now that I struggle with, not, you know, don't let me think about this thing from my past, right? So those of you who are in this training today, if all you get from this, and probably NAD in the state of Oregon would like it if you got more than one thing. But if all you guys walk out of here with is helping other people in an individual's life understand this, that it's really not about redirecting or distracting or hoping they'll forget. It's about supporting people living with a brain and a body and a nervous system that may quite literally have been reprogrammed by the amount of stress they've been exposed to. Okay, I told you there was a lot going on. All right, so Then he says, it's the physical sensations with which you live that become intolerable. Very quickly, I will tell you a story that I talk about in my book about sort of my introduction as a clinician to trauma. So I had a professor who grew up in rural Ohio, and like a lot of country boys at the time when the Vietnam War started, he volunteered to go serve his country, and he spent a year serving as a medic in the war. And so what that meant was that he would fly in helicopters, risking his life. Everyone on board risked their life if they'd been shot down. They would grab soldiers. I will not describe to you how that turned out sometimes, and get them onto the helicopter and try to keep them alive long enough to get them to the medical base. And needless to say, many soldiers did not survive that flight. So he did this every day for a year. That was his job, every day. And then he came home and he became a professor and a clinician. And then one day here in Columbus, Ohio, he and his wife decided to go to the movies. And the movie they decided to go see was called The Deer Hunter. Some of you may know that title, some of you may not, but it was one of the first very, very graphic, realistic movies about that war. And the story that he told generations of graduate students after was that he no longer knew what had been on the screen. He didn't have access to that because his brain didn't record it. All he knew was that one moment he was a PhD professor sitting next to his wife. The next thing he knew, he was crouched in the middle of the movie theater aisle screaming incoming while his wife and an usher were dragging him out of the theater. So you guys, I presume, did not know my professor, who's now since passed away. So you'll have to take my word for it when I tell you that he did not decide to do that. He did not choose to do that. And that seems probably pretty obvious to you, right? Why would I make such a point of that? Well, I want you all to ask yourselves a question, and we can just be really honest, right? And this is the question I want to ask you. Imagine that instead of being a PhD professor who seconds later, as he sort of came out of it, could sort of get control of himself and explain what happened and reassure his wife, who was terrified. Imagine instead that this was an adult in a group home who has a developmental disability of some kind, or a teenager or a kid in a special ed classroom on an outing. What would that person be told when they got home from the outing? I think we know the answer, right? That's the end of movies for you for the foreseeable future, or you just lost your privileges, or whatever. Why? If we were all in the same room together, we could all say it together in unison. Because of your poor choices, or because of your behavior. And this is something that if you're in the mental health world, may be a little bit foreign to you. If you're in the DD world, you'll immediately know what I'm talking about. Compared to mainstream mental health, much of DD relies much more on a behavioral approach to things. And there are reasons for that, and there's a history to that. And like anything, I think behavior approaches can be very powerful tools. But the problem is that people tend to write off everything as behavior. And again, from a mental health perspective, I come from the place of people aren't just what they're doing. Their behavior is a part of how someone's feeling and how someone's thinking. But also, and this is really important, behavior is a decision. Behavior is a choice, right? It's something I've decided to do. So if we were doing this training and I started having a full-on grand mal seizure right now, fell to the floor, I don't know if I would still be on camera, but I'm like, seizing on the floor, none of you would think to yourselves, what an odd choice she's making. I wonder why Laura decided to do this. It would be clear to you that what was happening was not voluntary, right? And in fact, when we talk about trauma, and specifically when we talk about flashbacks, like my professor experienced, that is neurologically much closer to a seizure than it is a choice, right? The thinking, deciding part of the brain is relatively inactive in that moment, in those few seconds. And yet, if you have a developmental disability, if you are dually diagnosed, what you guys need to know is that people around you, staff, family members, employer, whomever, unless they're very well educated and very attuned to this, there is a sort of an unconscious bias to write this off as a behavior. In other words, it was deliberate and it was a choice. So now, instead of getting supported for what was a horrifying experience for me, I am being, this is not the language that would be used, but the reality is I'm going to be punished, or at least I will have consequences for something that was involuntary, right? So again, why is this so important that you guys are here? Why did I become so passionate about talking about trauma and DD? It's because of that fundamental misunderstanding. And some of you today, depending on what role you play in your job, or later on in your career, you may be the ambassador. You may be the advocate for that person who helps explain trauma and who helps other people understand what, in fairness, is very odd, right? If you don't know this person, if you don't know what's going on, if you're just in the movie theater and someone starts screaming out of nowhere, I get it. I get why people don't understand what's happening. But this is a profound problem in the DD world, that we lack this understanding and that people are not getting the support that they need and deserve because we may misinterpret something as a choice that they made. Now, the last thing, and I told you there's a lot in this paragraph, the last thing I want to touch on here very quickly is when he says the physical sensations with which you live. Now, I want you to ask yourself, if you're in a movie theater, what would it take to make you jump out of your chair, leap out of your chair, crouch in the movie theater aisle, and start screaming? That would have to be a pretty intense level of terror and horror to make you do that, right? So when van der Kolk says the physical sensations become intolerable and you will do anything to make them go away, let me tell you guys what I would be willing to do to make that stop, that level of terror stop. I would be willing to drink too much, use drugs, overeat, starve myself, burn myself, bang my head, have sex with inappropriate people, compulsively spend, compulsively gamble, you name it, be physically aggressive, absolutely. If I had no other means of making that stop, I would be willing to do any of that and more. And what's more, so would you. And in fact, in this paragraph of very important things, I think the most important word is actually that. I think the word you is the most important thing. And when he was talking to this audience, I can tell you that van der Kolk did not say, you know, if you're a messed up veteran with problems, or if your brain doesn't work right, or, you know, well, he didn't say any of that. He said you, and he meant you, everyone in the audience. Right? Given the right set of circumstances and not having any other tools with which to deal with it, you would be willing to do almost anything to make it stop. So again, why do I say this? Because if you are the staff person or the family responsible for somebody who runs out into the road or becomes violent or smears feces on a bedroom doorway, I did not make that up. Whatever it is, it can look bizarre, it can look terrifying, it can look weird, it can be annoying, right? I get it. But if it hasn't started already, there should be a little Rolodex in your head, right? So if you've worked with clients who are dually diagnosed and you've struggled, you know, to try to figure out what the heck is going on with them, some of these names and faces might be popping up for you. Obviously, I'm not going to say it's all trauma for all of them, but when we start to look at things through that trauma lens, some things start to make a little more sense sometimes. Okay, so much good stuff there. We're going to go to the next slide. Have to talk about this one. Okay. Of all the quotes that I've started with, in some ways, this is my favorite. It's the shortest, but I think in some ways it's the most elegant and profound. Pierre Janet, for those of you who aren't familiar, was a 19th century French neurologist at the dawn of what we would consider modern brain science. And this is what he had to say about trauma. Trauma is a disease of not being able to be here. And I think that sums up for me, out of everything we've talked about so far, why I'm so passionate about this and why I'm so grateful that, NAD and Oregon gave me an opportunity to be here with you guys and the other places where I get to go talk about this. So imagine that scenario in the movie theater happened to me, not just that one time, but it happens to me a lot. And it happens when I have a staff person working with me, or when I'm trying to have a job, or I'm living at home with my aging parents and I'm getting big and hard to control. Am I, let me ask it differently. Let's go back to the movie theater example. Was my professor in danger at that moment when he started screaming? No, of course he wasn't, right? He was perfectly safe. But that didn't matter because his brain was experiencing something else in that moment. So when I'm reacting in some kind of similar way, or I'm shut down and I'm in a fetal position and I'm non-responsive, whatever it is, with that staff person or with my parents or in that apartment that I'm trying to stay in with a roommate or in that group home or classroom or whatever it is, am I reacting correctly to my environment? No. And yet, if that happens often enough, two things happen. Number one, my options for being able to be in the world get smaller and smaller and smaller and smaller and smaller for no accurate reason, right? I am cut off from all of these opportunities because I'm not interacting with my environment correctly, not accurately. My brain is not reacting according to what's actually happening to me. I'm not actually in danger, right? And more than that, and we'll talk briefly about this today. Again, this is a bigger conversation, but the more profound tragedy of this is that I also become disconnected from myself. So it doesn't just threaten my ability to connect and interact with the world, but the ability to be in my own skin versus the need to numb out and disconnect and anesthetize myself can be so profound that I'm not really living as myself anymore. And so I really don't get to be here. And when we engage in understanding trauma and creating some of the circumstances for healing trauma, really what you are doing by being willing to do that, and hopefully this training is a small part of that, then you are positioning yourselves to allow people to reclaim themselves and their lives. And I am not being dramatic when I say that. So we're going to investigate a little bit about what I'm talking about when I say that. So let's go ahead to the next slide. Let's see what on earth that is. Okay, really quickly, as I said, we're not going to spend a lot of time on definition, but this one's important. Trauma can be something that is literally physically threatening, or it can be something that feels emotionally annihilating and overwhelming, right? So if I am in a car accident and I'm trapped in my car for hours and I'm helpless while they're trying to cut me out and the car might catch fire at any moment, am I at risk of dying in that moment? Yes, absolutely, right? My life might be in danger at that moment. Or now imagine that I'm 4 years old and I live in a house where there's a lot of chaos and violence and screaming, maybe substance use, mental illness, whatever. And I'm not physically harmed. No one ever physically hits me or hurts me, but I'm exposed to all of this day in, day out. Would that be emotionally overwhelming and annihilating for me at 4? Yes, absolutely. Why I make such a point of this is that we tend to, as human beings, put ourselves in someone's shoes and say, well, I don't see why that's so stressful. It doesn't matter if you would find it stressful. It matters how that person experienced it, right? And we also tend to think that what happens to the body is more important than what happens to the mind. This is changing, actually. This is not as true as it used to be when I started doing a lot of these trainings around the country like 15 years ago. So I find that we have a better understanding of things like emotional abuse and verbal abuse and manipulation, and that's wonderful. So I don't have to hit this as hard as I used to, but I think it still is worth saying that what happens to the psyche, what happens to us emotionally, if we are emotionally overwhelmed with stress, the brain doesn't distinguish between those states, right? So we see the same damage in trauma. In fact, there was one study that talked about, now, again, this is one study, I don't know how generalized this would be, but one study showed results that brain scans of a soldier who'd been exposed to trauma in combat, a young child who'd been sexually abused, and someone who'd been in a long-term abusive relationship. I think it was like a 30-year marriage or something. The changes in volume in different regions of the brain were the same. So we may describe it differently, we may prioritize things differently, but your brain probably doesn't. Okay, so next slide as we fly through this. Okay, so I have these next slides here because when we think about trauma, we tend to think about triggers, right? So if you knew my professor and he told you the story of what happened at the movies, you might think very reasonably, no more war movies for you, right? And that would probably be a good idea for him. I don't think he did go to any more movies about the war after that. At least that was the rule that his wife had. So it's fine if we identify a trigger and I don't know, Jessica, I think you have like sort of honey colored hair. It's very pretty. If I am your new individual, you're my staff person, I take one look at you and boom, take a swing at you because somebody with that kind of honey colored hair had mistreated me in the past, you might think, wow, we need to staff Lara with someone else. That's fine. The problem, there are two problems here. One is that, and if you've ever worked with trauma or dealt with trauma, you probably already know this, that sometimes triggers are fairly obvious and other times they're not. So the best example that I have for this, for why you shouldn't get too fixated on identifying triggers, is that the problem with trauma is the brain. And one of the problems is actually one of the best things about our brain. And that is that your brain gets better at whatever you ask it to do a lot of. So if you're trying to learn how to drive a car or play the piano, that's great. It's not so great with trauma because every time your brain goes to that sort of emergency state, right, when something is overwhelmingly threatening, that gets quicker and stronger every time, okay? So the best example I can think of for this is a smoke detector in your kitchen. So imagine that you burn some toast and of course the smoke detector goes off and you're like, oh, you've got to fan it and get the toast out of the room and, you know, reset the alarm. So far, so good. But now it gets more sensitive every time that happens. So the next time you haven't even burned the toast, you just toasted the toast and it goes off. And you're like, oh, you've got to, you know, reset it and fan the air and all of that. And then it happens when you're boiling eggs and there's no smoke at all. And then the next time you're just boiling, you're just running hot water in the tap. And so on and so on. And every time it gets more and more sensitized. So eventually for some people, it goes off in the middle of the night. Nobody's even in the kitchen. Anybody dealing with severe trauma will tell you that sometimes they can identify a trigger for what caused them to become dysregulated. That just means they go into their emergency protocol like a fire alarm, right? So when the fire alarm is going wah, 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 like your smoke detector, that means they're either in fight or flight, which we're going to talk about, or they're the other side of that. It's the other end of the range, but it's the same reaction. And that's when they go into a state of dissociation or collapse. So you either get very mobilized or you get very shut down, but they're really just that same emergency system kicking in. Okay, so the problem is with some people, that system is now just kind of setting itself off and you're never going to identify all the triggers. But that's not even the biggest problem. There's an even bigger problem, and that is that depending again on how early, severe, or chronic that trauma may have been, it can affect everything about someone, not just triggers in a particular scenario. Okay, so for this, I like to think about a boat on the ocean. Fortunately, a lot of you guys live near the ocean. Lucky you. And so imagine that you're in a boat on the ocean and there's a little hole in the side of the boat. Initially, where does the seawater go? Well, it'll just seep in at the side of the hole, right? But if you don't know about it and it just goes, you know, the problem goes on and on and on and on, where does that water go? Well, seawater will get everywhere. It'll go everywhere into that boat. And given enough time, it can bring down the whole thing, right? A massive ship, it'll take it down. And so if we think about triggers, we kind of miss the point that for many of the folks we are talking about with dual diagnosis, we are, for many of them, talking about early, severe, chronic, one or more, or all three, right? So for some of these folks, that seawater has gotten everywhere. And so these next couple of slides are just various examples of how profoundly trauma can impact everything about a person, whether we're talking about their body and their immune system and their nervous system, or how they see the world or see themselves or interact. Okay, so trauma can affect how aware you are of your thoughts, feelings, sensations, and where your body is. Yes. Again, the more severe the trauma, the more we see this. But remember when I said that you would do anything to stop feeling the intense distress and terror that trauma can produce? Well, especially if you don't always know what's going to set it off or how to stop it, the answer, of course, is that you try not to feel it. So you either numb yourself through external things like substances, for example, or you do it internally. Often people do both, where I just kind of shut myself off from my feelings. And unfortunately, we can't do that selectively. If you're going to not feel, if you're going to remove yourself from your thoughts and feelings in your body, and some people will actually talk about that, especially children. If any of you work in kid world, if you've worked with trauma, you know that children are often very adept at kind of leaving their body. And some people will actually experience it like they're looking down at their body or they're watching it happen to someone else or whatever. The problem is you disconnect yourself from all of it, not just the bad stuff, the good stuff, everything. And so, and again, Vander Kolk in his book, which I highly recommend, talks about this in great depth, that people walk around not knowing how they're feeling, not knowing how they're thinking, feeling disconnected. That can be very subtle or it can be very obvious. How you react, think, judge the intentions and actions of others. Again, when I worked with teenagers, any of you who've ever worked with that population, or I see this a lot in corrections, if any of you have any corrections experience, I used to think with some of my kids that if they had had an extra second and a half of time before they reacted to get in that car, or to not get in the car when they did, or not throw that punch, or not do that thing, their lives would be so profoundly different. It often comes down to that much. And so when people, because of trauma, either overreact really quickly, you bump into them and they turn around swinging, or the opposite, they're numb, they're disconnected, they ignore obvious warning signs. People who've had repeated trauma, let's say from relationship violence, sometimes it seems like they just keep doing the same thing over and over again. Part of that can be that they are slow to react to what would be for most people a signal of danger to get out, right? I could go on and on. These are just a few examples. We'll go a little more quickly through this. How much you can ever relax in your own skin. We all went through COVID, right? And we're now, I think, all immunologists, I think, from the internet. I don't know about you guys. I got several medical degrees online from doom scrolling. And so we're all learning more and more and more in the most immediate way about what chronic stress does to us. And so things like lowered immune system, gastrointestinal issues, chronic headaches, there's increasing evidence of a strong relationship between stress and autoimmune disorders, as well as other things. So it does a number on your body if you never feel like you can fully relax. I'll just leave it there. Next slide. In my longer training, I talk a lot about the mechanisms of empathy and why people with severe trauma histories can look like they lack empathy, which makes them look sociopathic. It can make them look like criminals. And again, any of you who've worked in corrections, you know that the rate of trauma in that population is like practically 100%. So there are reasons why people seem numb and cut off from the feelings of other people. Sometimes it's sociopathy. I think more often it's childhood trauma. So you guys get the idea. We're going to move through these. So we'll go to the next slide. Okay, so if you study trauma or if you work with trauma as a therapist, so kind of a shorthand we have is big T and little t trauma. So big T traumas, the simple way to say this is anything where you only have to go through it once for it to potentially be traumatizing. Not everyone's going to react the same. But if I told you that I think there's a book out right now and maybe a movie about a survivor of a plane crash. Someone tell me about this. So if I survived a plane crash, and I told you that I was having problems with trauma as a result, none of you would be confused, right? None of you would be like, "Oh, was it just the one plane crash? Huh, weird." You would get it, right? So big T trauma can result from in some cases, a single event that is so life disrupting that it causes ongoing issues. So things like sexual assault, physical assault, or, ongoing mistreatment, of course, verbal or emotional abuse, war, natural man-made disasters. We can go to the next slide. So we'll go, yeah, there we go. Some invasive medical procedures or catastrophic illness, traumatic grief, humiliation and bullying. You guys get it, right? These are the kinds of things where they can be so life-altering, so profound that they just rearrange kind of how our body is experiencing being in the world, right? So we have trouble with flashbacks or nightmares or anxiety or what have you. Again, pretty intuitive for most people. Okay, next slide. But there are also little t traumas. So now let's go to the next slide. Okay, ordinary life trauma. I could have called this, if you look at the stuff on this list, feeling different, being othered by other people, not feeling accepted, not being able to do stuff other people can do. There's other stuff on the next slide. We can just go to the next slide. Not being listened to, feeling misunderstood. I could have called this slide 7th grade. Right? I have yet to say this to an audience where I go, raise your hand if you've never felt any of the things on these 2 slides, and no one ever raises their hand because we all had to go through middle school, right? So if experiencing these things sometimes, feeling left out of a group or feeling ostracized or feeling devalued or misunderstood, if that's just part of being a human, then why are we including it in a discussion of trauma? And the issue here, what is different from the previous list of the big T traumas, the little t traumas, they're not about the severity. They're about the cumulative quality, right? How often they happen. So most of us, I make a little hilarious joke about 7th grade. 7th grade was pretty traumatizing for some of us, actually. But most of us share a couple of things, right? One of them is that these things may still happen in our lives occasionally, but they're probably pretty infrequent, right? Hopefully. And if they do happen, you guys in the audience today, you've probably got robust ways of coming back from that, right? So let's take failing at a task, okay? When I was learning to drive, I started driving kind of late. And I was like 25, and so I had to learn how to drive, which I was not immediately great at. And the first time I took my lesson, I failed. And I felt awful. It was embarrassing. Everybody was really excited for me, and I had to be like, no, I failed. And it did not feel good. I had that like, feeling. So what did I do? I studied harder, right? Practiced more, and I took it again. And I passed. I'm still not a tremendously good driver. You can ask my husband or my kids and they will verify this. I'm not the world's best driver, but I was able to sort of, try again until I was able to turn it into a success. Or I might say, the hell with it. I'm just going to move to Portland and then I can take all this wonderful transit and I don't know, kayak to work and it'll be great. So in other words, we have resources for, becoming successful, or we can say, okay, well, I'm just not going to do that. I'm going to go in this other direction. And we also all have something that many, many people with dual diagnosis do not have. And that is a robust natural support system. Now, some of you may go to therapy or you have a life coach or, whatever. I'm a therapist. I think that's great. Therapy for everybody. But most of the people in your life that would be there to kind of pick you up, that were there for me, it's all right, Tiger, you'll get them next time. Those were not people who were being paid to be my friends or family. Now, this is not to diminish the importance of the staff and the case managers or the SSAs or the people in the lives of folks with dual diagnosis, but it's different, right? It's different if someone's there because of that natural tie and that natural bond. So, in fact, this is an area of huge importance in the world of developmental disabilities, and that is the issue of loneliness. So that, again, is a whole conversation for another day, but I'll just say this, that the issue here is that many of the folks that we're talking about with dual diagnosis do not have those things. And we're not talking about something that happens once in a while. If you go back and look at this whole list again, how often someone feels confused and overwhelmed, how often they feel they're not being listened to, or that they're different from everyone around them, or that they're being devalued, or whatever it is. How often does that happen? Well, for some of our folks, it's day after day, month after month, year after year, decade after decade, right? So what happens in the brain when we have those smaller little mini traumas of that emotional distress is that add up enough of those small things, and it starts to make the same kind of brain change that we get when we're talking about big T trauma, right? So cumulatively, they start to look the same. So if we go to the next slide, my absolute favorite quote about this is from a friend of mine who is a retired lieutenant in the Ohio Highway Patrol, who's now nationally involved with working with first responders in trauma. And this is the way he explains it to police officers and firefighters and EMTs. Big T is like being attacked by a bear, and little t is like being attacked by ducks. So I like this because it's kind of a fun image, but you sort of get it, right? The damage from a bear attack is profound and immediately obvious. A duck, if it's a duck every once in a while, I can probably fight off a duck, not a goose. I'm terrified of geese. I run away from geese. But a duck, I feel like I can handle. But given enough time and enough ducks, and the damage starts to look the same. Now, the reason I spend time on big T and little t, really there are two reasons. One is that sometimes when I do this training, people they kind of get excited about centering trauma, which is wonderful. And like when we go around to different states or providers, sometimes people will say, we need to start screening our folks for trauma. And my partner and I always say the same thing. Yes. And you're going to miss some stuff, because there are instruments out there that can sort of be inventories for big T traumatic events in someone's life. The problem is that in the DD world, sometimes we're dealing with someone who's quite advanced in age, and we may not have the records of their childhood. It's not the same as in mental health. If you're working with a kid in the mental health system, you probably have a lot of that information. That's not always true with developmental disabilities. And there hasn't been the emphasis on trauma that there is now. So you may miss some of those big T events because they didn't tell anyone, or they weren't believed, or it just happened too long ago. Nobody knows about it. But the other issue, and I think this is a bigger problem, is that while there are instruments that can measure some of those big T events, I've never yet seen an instrument that can capture how many times in a day someone feels devalued or misunderstood or overwhelmed or disempowered. So maybe we'll have that someday. But right now, it's important that we know that any kind of formal screening tool will only do part of the job. I'm going to talk about why I make such a point about that in a minute. So let's keep going. Okay, as I said, we're not going to spend a lot of time on diagnosing trauma. I don't think that's terribly important. And for this, instead of going through each one, I'm just going to kind of show you guys. When someone, those of you who have a mental health background may be more familiar with this, but if someone is given a diagnosis of PTSD, they have to have had a certain number of symptoms in these 4 clusters of symptoms. There's some other factors too that they look at, but these are sort of the what it looks like for somebody, right? And we've already touched on these things. So the first one, hypervigilance. This is where it just like it sounds, you're always on red alert. You can't relax. So we may, in people with dual diagnosis, we may see pacing, rocking, literal tightness of the muscles, irritability, those weird unexplained headaches and stomach aches that nobody can quite diagnose. These are the kinds of things that we'll see in hypervigilance. People, for example, who, if you come up behind them or if they can't see the door, they're more likely to act out violently. That may very well be hypervigilance. They need to see how they can get away from you. Avoidance, this used to be called constriction for some of the OG clinicians. I remember when it was called constriction. It just means kind of what it sounds like, that you will avoid things. And again, remember that seawater creeping into everything, right? You sometimes will get more and more and more avoidant of life to avoid trying to be, to try to avoid being triggered. So people who don't like to leave their house at night, who have a lot of difficulty trying new things, or who don't handle changes in routine very well. Now, when you're talking about dual diagnosis, you may also be talking about things like folks on the autism spectrum, and they may also have some of those things, some of that rigidity. So I'm not saying that this is the only reason that you might see this in someone with dual diagnosis, but it is a classic presentation of trauma, that you kind of make your world smaller and smaller and smaller to try to make it feel manageable and to avoid those triggers. The next one, this is kind of what people think of when you think of PTSD, and that's what happened to my professor in the movie theater. So flashbacks, nightmares, intrusive thoughts, stuff like this. This is, by the way, the only symptom cluster that we have a specific medication for. It doesn't help everyone, but it does help a significant number of folks. It's called prazosin, and it does seem to help prevent nightmares because it kind of keeps the blood pressure from spiking up to have that happen. Negative alterations in cognition and mood is a typically exciting DSM way of saying that trauma can produce feelings of depression and anxiety. Yeah. And it can negatively impact how you understand yourself in the world. You can walk around with some pretty distorted, defensive ways of predicting how other people will be with you. And it can absolutely just devastate our ability to see ourselves as valuable and worthy if we've experienced trauma. So when someone is talking about, clinical PTSD, this is what they're talking about. Okay, so next slide. So fast, so much to tell you guys, so little time. When someone has a developmental disability or anything that prevents communication or easy communication, then you will see the nonverbal stuff more, okay? So you may see more of what we call somatic complaints, and that's true of the general population, by the way. One study suggested that about 30% of the general population experience any kind of emotional distress more in their body than they're aware of experiencing it as like a thought or an emotion. So they may not describe themselves as depressed, but they have, chronic fatigue or chronic headaches. This is even more the case with folks if communication is difficult for them. So we will see this non-verbally, either in the way that they're acting in the world or in these, especially when they're sort of mysterious or hard to pin down medical things. I think we should be considering stress as a major factor for that. Moving ahead. Okay, so I talked about this. Most folks are familiar with fight or flight. I did want to spend just a moment with you on this. So when we talk about fight or flight, the clinical term that we use for that is hyperarousal, and it's just what it sounds like. Your arousal level, how activated your nervous system is in your body. We normally are in sort of a middle range, right? So like right now, hopefully, you guys are all regulated. That means that you're in that kind of normal range for your blood pressure, your heart rate, your breathing, how much you're sweating, how active your brain is, all that stuff. It's in hopefully a normal range for you. You're not falling asleep. You're not super excited. You're somewhere in the middle, right? Okay. That's where most of us live most of the time. When we become hyper aroused, that is that emergency system kicking in, as I mentioned, and that's just to keep us safe. So imagine that you're driving on the freeway and someone doesn't see you and they're merging right into your lane and you jerk your car out of the way. You are probably experiencing heightened arousal at that moment. So your heart's pounding and maybe you're like, kind of breathing fast, and maybe you're a little shaky from all the adrenaline. That's hyperarousal, and it's there to keep you safe, just like it did, right? So it sped up your reflexes, got you out of the way, or you're ready to run away from the bear, right? Okay, so most of us are familiar with fight or flight. That's this little phrase we all have that just rolls off your tongue. There are actually two other states that are important to recognize. One is freeze. Okay, so for this one, I need you to imagine that, I don't know what wildlife you guys have in Oregon. You have deer, right? Not moose. You're not south enough for moose, I don't think. All right, so let's use a rabbit, actually. That's a little easier. So you're driving at night and a rabbit darts in front of your car and freezes in front of you. All right, so right before you swerve out of the way, hopefully, if you had time to look, you would see that that rabbit is perfectly still, but you can almost see it vibrating with tension, right? So it's still at a high level of activation. And as soon as you get your car out of the way, or the headlights get off of the rabbit, what does the rabbit do? It boom, takes off, right? So it's still very mobilized and ready to run. But in that moment, it freezes. That's a prey reaction to try to avoid being seen, right? So it's stillness, but at a high level of activation. We'll come back to that in a minute. And then the last one is fawn. So keeping with our animal theme, fawning here refers to moving closer to a threat to try to neutralize it. So typically we're talking about a person, right? And usually what this means is that the person will try to, if that person seems angry or threatening or violent, they'll try to calm that person down through appeasing them or flattering them. It's why some of us may involuntarily smile when we're scared or giggle. Some people will be very placating or friendly or even seductive. Those of you who work in disabilities may be familiar with what we sometimes call the disability smile. And that is a really good survival strategy, right? If I'm always smiling and I seem really sweet and non-threatening, maybe I'm going to get what I need from you. Okay. Whenever someone goes, oh, this person with disabilities, I just love working with them, they're always happy. I'm sorry, I call BS. No human being is always happy. But there are some people, now there's some people who are just naturally cheerful and pleasant, but I do think that sometimes what we mistake as always happy, what we actually may be seeing is a stress reaction. Okay, especially when someone else is behaving in a way that's erratic or unpredictable or threatening or frightening in some way. Okay, and we can see people who identify male or female as doing fawning. It can be in either one. But women are already kind of traditionally socialized to do a lot of that stuff. So we may see it more frequently in women. But again, male identifying people, we can absolutely see the same thing. So when we're hyper aroused, we're activated, we're going to try to get away from the threat or neutralize the threat somehow, but we're still very active in our survival: fight, flight, freeze, fawn. Okay. Now, as I mentioned earlier, the other side of that coin is hypoarousal, and that is where I shut down. Okay. So for this, let's go back to our rabbit. And let's say that instead of freezing and waiting for those few seconds for your car to get out of the way, now the rabbit has been caught by a wolf. What does the rabbit do? It might struggle, right? But once it knows that it's, really caught in the wolf's jaws, it's not rigid and stiff like it was before. It's slumped over, it's soft, it's limp, right? You guys probably did not think there was going to be an acting portion. So I hope you enjoyed my portrayal of a rabbit. So why does that happen? That's also a prey reaction. If I'm about to be eaten by a wolf, I don't need to stick around for this. And maybe the wolf will drop me and I can, whatever. But even if the wolf drops the rabbit for a few seconds, it'll just lay there. So this is a state of collapse. All right. Another way to think about this is that in hyperarousal, it's like the alarm system in your building is going off. So there are lights and sirens, and you can hear the fire trucks down the street, and it's like wah, wah, wah. Everything's all lit up. With hypoarousal or shutdown, now it's like all the power to the building has been cut off. So it's dark, it's quiet, it's cold, there's nothing happening. I went to a wonderful training with a psychologist from California, and he described it as hyperarousal, you're being chased by the tiger. Hypoarousal, the tiger lives at your house. How would you behave if there were a tiger in your house? You'd be very quiet, and you probably wouldn't move around very much, right? So this is shutdown. Dissociation is just another aspect of this, and this is what we talked about before, where you kind of leave. Dissociation can sometimes be something as subtle as the word dissociation, I should explain, just means two things that are normally connected are now not connected. So it can be something as subtle as I'm telling you my trauma narrative, but I'm telling you like a robot. I have no emotion in my face. I have no emotion in my words. If you're not sensitive to that, you might think, oh, Laura's telling me this story, but she's clearly over it because it doesn't bother her very much. Nope. What you're seeing is I've dissociated the feeling from the words. Boop. Some forms of dissociation are more dramatic, where I talk about leaving my body, or, I'm kind of looking at it like it's happening to someone else. And in its most severe forms, that's when you experience people who like maybe kind of lose time or experience themselves as having different aspects of their personality inside of them. That's definitely a conversation for another time. But anyway, so that is the mechanism of survival. And what you guys most need to understand about that, we'll see in the next slide. I'm terrible at graphics, as you probably already noticed. So this is my one graphic. Yeah, let's click through just to get the next ones. And then one more, just leave it there. So, okay, go back two clicks. This is my one fancy graphic. Okay, so I hope you guys enjoy this. So as I said before, most of us walk around with that kind of middle band. This is where we live most of the time. And we don't go into hyper or hypoarousal very often, just very occasionally for most of us, like getting the car out of the lane or whatever. But again, remember what I said, our brain gets good at whatever we ask it to do a lot of. So now, Jessica, just give it one click. So the more your brain spends time in one of those two states, or both, because we can kind of go hypo and then, or hyper and then hypo, the rabbit tries to run away and then it's caught. The more time you spend there, the easier it is to go into that state, the longer it takes to come out, until finally, last click. Some of the folks we work with, most of the time, they are either agitated and in hyperarousal, right? That's one form of dysregulation. Or they're shut down and numb and checked out. That's another form of dysregulation. So you remember when I talked about that seawater, right? If you spend most of your time like this for years and years and years, pretty soon this is how people see you. You are your survival reactions. This is who you are. So I am violent. I am disruptive, or I am numb and passive. Not that I experience these things, but they become what I am. Bruce Perry, who's incredibly famous for childhood trauma, talks about the state, the brain state, hypo, becomes a trait. This is how people experience us, right? Okay, so moving on, we have I'm going to talk just a little bit more, and then we'll talk about this. Yes, so Bruce Perry, he also said this: people usually want to teach other people from the top down, but the brain actually works from the bottom up. And what he means by that, yeah, there's so much to tell you, so little time. What he's saying is this, that the brain has to feel that its basic survival is assured before it can do anything else. So think about this for a minute. Imagine wherever you are, that I gave you a list of, I don't know, what would be the worst thing I could do? Story problems, let's say. So I gave you all a bunch of math story problems. Maybe some of you love it, I don't know. And I told you to fill them out and try your best. And then at the same time, the fire alarm is going off, and you can hear the fire truck screaming down the street, and there's smoke rolling in under the door, and then a bear comes into the room. How are you going to do on that math test? Not great, right? Any ability you may have had to focus on that is now gone. The reason for that, and I go into a lot more detail in my book, or again, when I train about polyvagal theory, we spend a lot more time on the body and the brain and the nervous system, but I can show you guys this. So take your right hand or your left hand, doesn't matter, and curl your fingers lightly around your thumb. This is a reasonable representation of the kind of the gross regions of the brain. Now, some of our most current thinking actually shifts away from regional thinking, but this is still good enough for what we're trying to understand, okay? So imagine that your wrist and the heel of your palm here is the bottom of your brain, okay? So the brain stem and kind of the flat bottom of the brain, that's sometimes called the diencephalon. You don't need to know that. What that does is most of the basic functions of the body, right? So like when they invented the guillotine, the reason that it worked so quickly and was considered very humane is that when you cut the brain off right there, boop, people die really fast. So a little fun fact to share with everyone tonight at dinner, in its day, the guillotine was considered top-notch humane technology. So if anything is disrupting brain function down here, you're dead, okay? Now, if we go up the brain a bit and you look at where your thumb is in your fist, this is roughly the position of parts of the limbic system. Probably heard about this. The limbic system is kind of in the midbrain, and it's really sort of a conduit station for the top and the bottom of the brain talking to each other and side to side and back to front. The limbic system does lots of stuff in terms of regulating the function of the brain and body. It also is very involved with learning and memory and motivation and emotions. It's also where the smoke detector of the brain is, and this is the amygdala. Again, the brain can sort of reroute things more easily than we thought, but usually this is where that function is happening in your brain. So remember we talked about that kitchen smoke detector? That's the amygdala. So if you imagine, going back to your little hand brain, if you imagine two little almond-shaped freckles at the bottom of the thumbnail, the bottom corners of the thumbnail, that's roughly where the amygdala is in your brain. And the amygdala is constantly sorting through whatever's going on around you and what's going on inside you and asking the question, is Laura safe? And hopefully, most of the time, the answer is yes. You don't even think about it. You're not aware of it because, yep, everything's stable, right? So another way to think of it might be the thermostat at your house. If the temperature is within a certain range, then it's fine. And if the temperature creeps up or goes too low, the thermostat kicks in to re-regulate it. This is why you'll notice that I keep using the word dysregulation. Dysregulation is when the normal functioning that your brain likes for everything to be cool is no longer happening. There's something that has disrupted it. Typically, it's some threat from the environment. So, there's a car merging right into my lane and doesn't seem to see me. Well, that's a threat, right? And now the amygdala answers the question, is Laura safe? No. So what happens then? Again, very, very simply, oversimplifying it. So if we go back to our hand brain one last time, if you look at the back of your hand, coming up across the top and down to your fingernails, this is a pretty good representation of the cortex, which is that relatively thin layer of cells that come up and around the sides and down to the front of your brain, right to about where your forehead is. And this is, as brain scientists like to call it, the thinky thought portion of the brain. It's just my little joke. No one calls it that but me. And this is the part of the brain that is much more sophisticated in terms of decision making. So I'm walking down the street in beautiful, leafy Portland, and there's a branch on the sidewalk, but I glance down at it and it kind of looks like a snake at first. Maybe my amygdala, which is sorting through sensory information, just sees like, I don't know, long and brown and something snaky. And I look down and I go, oh, and I jump, right? I jump out of the way, I startle. And then I take a second look and my thinking brain has time to catch up because the thinking brain is about half a second slower, which doesn't sound like it's a lot of time, but in brain terms, it's really slow. So I glance down and I say, that snake appears to have leaves growing out of its head. That's unusual. I think maybe what I'm dealing with is a stick. So I get that maybe immediate, reflexive, evolutionary, keeping me safe from snakes function of the limbic system, but it's very crude. It's very fast, but it's very crude. Second or two later, my brain can fully catch up, and now I can actually assess things more accurately with more information and more sophistication. Why does this matter? Because your brain is ruthlessly efficient at keeping you alive. So go back to that, the fire alarm is going off and there's smoke and there's all this stuff going on. If we could somehow do an fMRI while that's happening, I don't know where you would be that would be happening, but if we happen to be scanning your brain in real time while that all happened, what we would see is the middle and the bottom of your brain are lit up like a Christmas tree, and the top part is relatively inactive, which again, from an evolutionary standpoint, makes sense. If a bear bursts into the room right now and my thinking brain gets caught up with, is that a brown bear or a black bear? Because what's that rhyme? Brown, good night, blah, blah. Like, bleh, I'm dead. By the time I've thought through all of that, I'm dead. All my brain needs me to do is to run and get away or play dead or whatever I'm going to do, right? So your brain shoves the resources where they need to be, operating your body and the simplest form of how do I get away from the bear, right? You're really not thinking. So remember that thing I said all that time earlier when I said that when we are in that survival state, that's okay. When we're in that survival state, we're not behaving. Now you know the neurology behind that, okay? That what is happening in those few seconds when my professor jumped up and started screaming was his thinking brain was relatively offline. So the ability to think through, am I in Vietnam or am I in a movie? Is it a survival strategy to start screaming, or is it disrupting a movie theater full of people? That kind of decision-making and choice, that happens in the cortex. Okay, technically it's the cortex talking to the limbic system. But so if that's not available to me, if that's not online, literally, then what's happening to me is involuntary. Okay. And so again, if it's a PhD professor, he can explain that. But if it's someone with dual diagnosis, they may not be able to. And they get treated as if they've made a choice when they haven't. The next thing is what we're going to wrap up with, and then I'm going to try to leave time for questions. And it's this, that trauma responsive care, the model that I sort of put together out of looking at the research and different models out there, looks a lot like other trauma models, to be honest with you, in two parts. But there's a third part that I think is really important. So in trauma responsive care, go ahead and go to the next slide. We say that people need to feel safe, connected, and in control. Don't worry about the vagal nerve stuff. That's part of a longer training about polyvagal theory. Safe, connected, and in control. And what that means is that if you're working with someone with dual diagnosis and for whatever reason, that alarm system has started to go off and they are dysregulated, the parts of the brain are no longer communicating in their usual way, and they are either hyper aroused, so they're flailing around, freaking out, whatever, or they're shut down, they're disconnected, they're numb, they're slack. Sometimes people will be in a fetal position. The emergency system has taken over. And you cannot get them to do anything else until their limbic system starts answering the question, am I safe? Yes. Whatever that means for them. So you get the triggering person out of the room, or you give them a hug if that makes them feel safe, or you back up if that's what helps them feel safe. You remind them that you're a safe and reassuring presence. Whatever that is, and it can take a long time, because if I spend most of my life in that red zone or blue zone, I may go up very quickly and it takes a long time to come down. But your first order of business is to help me feel safe, whatever that is for me. When I start to feel safe, my brain will come back online, right? And now the cortex can talk to the rest of the brain. Now I can start making some choices. Do I want to keep punching my staff person, or would I be okay with taking a walk? Now you'll notice that I skipped a step, and that is connected. Why did I skip that? This is where trauma responsive care comes in. And I should tell you this, we called it trauma responsive care because increasingly we're seeing that people are getting trauma informed care, and that's a critical first step. And more people have at least some trauma-informed care training. Trauma responsive is meant to be kind of the next step. How do you actually interact with that person to help them in that moment and also set the stage for potential healing, which I'll try to have just a moment to talk about. All right, so how does connected come in there in the middle, in the little middle of the sandwich? Well, the brain has ways of turning things on and turning things off. And when the switch is flipped for the alarm system, that is mediated, as they say, in the brain by many neurotransmitters, those little chemicals floating around in my brain, primarily, among others, norepinephrine and cortisol. When my brain starts pumping out norepinephrine and cortisol because I'm stressed, there's a threat, that signals the adrenal glands on top of my kidneys. They start secreting adrenaline. My body is flooded with adrenaline and cortisol, and that gets me in that fight or flight state. Or I shut down, okay? But it's still two branches of the same tree. I'm now in my emergency system. Well, if the brain has a way to turn something on, it always has a way to turn it off. Otherwise, you'd start scratching your nose and you wouldn't stop until it fell off. So the off switch chemically is, among other things, dopamine and serotonin. When our brain starts secreting dopamine and serotonin instead, dopamine and serotonin actually break down the chemicals of norepinephrine and cortisol, literally dissolves it, right? That's pretty cool. And we all had a lesson in this during the pandemic, especially early on when we were all really scared and really freaked out and really unsure of what was going on. What did we do? Did most of us eat a kale salad and sit down to do our taxes? No. We ate mac and cheese and we cuddled on the couch and we watched Netflix. That's what we did. We were instinctively looking for ways to get our brain to release dopamine and serotonin, okay? Love, pleasure, connection, warmth, mac and cheese, okay? Sometimes I refer to them as the mac and cheese chemicals. So when we help someone to feel connected, and that can be based on a long, trusting relationship, or it could be somebody I just met an hour and a half ago, like Jessica. If I'm able to communicate, Jessica, it's okay. You're safe. I'm with you. We'll figure this out. We'll get through it together. Now, that's not a magic wand. It doesn't instantly make everything wonderful. But what starts to happen is her brain starts releasing dopamine and serotonin. That helps her brain get back online. And now, if she has some language, she can start talking to me. And if she has, choices that she can make, she has a better chance at accessing those than when her brain is disconnected or dysregulated. So we say that people need to feel safe, connected, and in control. And who needs that? Remember when we talked about the problems with screening for trauma? Well, the answer is you should treat it like a universal precaution. Treat everyone with dual diagnosis as if they need to feel safe, connected, and in control. The reason for that is that if you look at the rates of big T trauma and little t trauma and you put them together, estimates for trauma, when you talk about both of those kinds of trauma for this population, are upwards of 90%, more than 90%. So whether you know their trauma or not really is irrelevant. If you treat it like a universal precaution and you help everyone to feel safe, connected, and in control, and someone doesn't have any significant trauma history, okay, who doesn't want to feel safe, connected, and in control? It's fine. But for all those people where you suspect there's trauma, or you don't know if there's trauma, or you have no idea why they're experiencing what they seem to be experiencing, starting with feeling safe, connected, and in control is the trauma responsive way to do that. And I'll say one last thing before we go to questions. I know we spent so much time going through this material, but it's all important. I will say this. The bad thing about trauma is that the brain gets good at whatever it experiences over and over again, right? But the way out of trauma, the way towards healing from trauma, is when you experience something different over and over and over again. So some of the folks that you work with may have profound trauma, and I can't tell you they will all perfectly heal from it, but I can tell you that whether it's your interactions and your relationship with them, or the work you do to support the people who are going to have those relationships with them, when these individuals can feel safe, connected, and in control over and over and over and over and over, that's how brains start to heal. And I don't believe there's any limit to the potential of healing in human beings. So we'll go to questions. I can stick around if people can stick around, even though I know this is supposed to end in like 2 minutes. But before I go, I have to do this, and it's simply to thank you. Thank you for everything that you're doing. Thank you for whatever role you play in allowing these opportunities for these safe, connected relationships and interactions that these individuals can have, because you represent their best chance at reclaiming their lives. And I can't think of anything more important. So thank you for that. And thank you for your attention. So that was very fast. We'll pause there and open it up for comments and questions. And like I said, if folks want to stick around, I'm happy to do that.
Yes, Jenny, go ahead.
Hi, yes, thank you so much, Lara. I wanted to ask you if in your work, if you ever speak to behavior analysts who are trained in modifying behavior, because what I see a lot is people with intellectual and developmental disabilities are pushed down this behavior pipeline where people look at them as behavior to control and modify instead of looking at them as traumatized humans, and that perpetuates the trauma and continues to traumatize them. So I'm just wondering if you ever speak to that particular group of people about this.
I do. First of all, thank you, Jenny, for all the stuff you just said. Again, in a longer conversation, we could talk about kind of why that is, and there are some very real, understandable reasons for that. But I will say this: the behavior folks that I talk to, number one, typically I'm preaching to the choir because they're in this training, right? I have found that behavior folks that talk with me are very open to this, and the idea that behavior techniques can be powerful tools, but if you're not seeing it in the larger context of this actual human being, and none of us goes, gosh, I wish someone would help me modify my behavior. We're usually saying, I wish I were understood. I wish I were connected. I wish I were cared for. So is everybody on board with that? No. Is the field shifting? I like to think so. But yeah, I've never met anyone who says, boy, what I would love is for someone to have a behavior plan for me. So that's how I try to talk about it. But I love everything you said, and I'm right there with you. Any other comments or questions? And like I said, I want to make sure we have time for folks who are open to doing that. I'm also going to look at the little comment section here. Oh. Let me just say, Jenny, you've got a comment here about ABA. Oh yeah, we could talk about ABA. Let's see. Not being, Jenny, you also said, God, you said a bunch of good stuff. Not being listened to is perpetuated by planned ignoring in ABA therapy. My son has PTSD from this for sure. And don't even get me started about restraint. So again, I'm not going to say, I'm going to throw out everything about ABA, but I think it needs to be at least profoundly reconceptualized for many, many people. In our ableist society, it would be rare for someone who has DD not to have trauma from all the systems. That's from Amy. Amy, I would agree with you about that. Let's see, anything else? La, 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 la. Okay, folks introducing themselves. Great, awesome. I want to open this up, and Jessica, let me know, is there anyone else that you want to sort of put on camera or?
Looks like we have a question from Isabella.
Okay, hi, Isabella.
Hi. So I'm actually a therapist in training right now, and I just had a client yesterday. She's 16, dual diagnosed, and I was just wondering if you had any resources that you really liked, especially for kiddos. Yeah.
Oh, that's such a great question. Unfortunately, trauma and developmental disabilities generally is still there's more, but there hasn't been a ton. So the first thing I would say is any kind of therapy you're doing with her, as I already kind of started with, good therapy is good therapy. Some modalities are better than others. Does she have any issues with communication?
She's not super verbal, but she's able to respond to questions when I ask. Her memory's not very good either, her recall or her short-term memory. So
okay. Oh, I would think a couple of things. The one of the places where trauma and DD interestingly intersect is that, as you're probably aware from your training, most of the cutting edge trauma therapy for severe trauma is moving away from only using talk therapy, right? Because talk therapy, even like, I'm not a CBT therapist, I think CBT is great, but it's not a cognitive issue, right? It's a brain body issue. And so if you look at all the stuff that's out there, whether it's EMDR or I just did a training, if I may say so myself, a really cool, exciting training at the NAD conference in Ohio with a dancer that I was lucky enough to meet and who did some dance work with us. Anything involving movement, rhythm, all of that regulating body stuff can be really, really helpful. I also really like play therapy. And I want to be very clear. I think play therapy is for every age. So this is not to infantilize her. Yeah. I would start going towards the non-cognitive stuff.
Yeah.
And again, whether you identify trauma as a target or not, I think this is really regulating and that's really helpful. So
awesome.
Those are some of the places I would look.
Yeah, thank you.
Oh, my pleasure. Thanks for that. That was a great question, Isabella.
Amy, go ahead.
I would, if I'm allowed to respond to Isabella too, I am not a therapist, but from someone, a parent with lived experience, connecting through their special interests is a big way to get people to open up.
Yes, so, thank you. I should have started.
Whatever their special interest is, you know, you might have to have many, many sessions talking about Pokemon or whatever the thing is. Mm-hmm. But you will learn a lot through that as well.
Yeah, that's true. Thank you for that.
So much, Amy.
This is great, you guys. This is a really good conversation. I don't usually get to do this.
Did you have another question, Amy? Or I see Jenny's hand up again as well.
Oh.
Go ahead, Jenny.
Yeah, no, I was just going to say that, like, from my lived experience with my son, who is autistic and blind, that relationship has been the #1 healing thing for him. And when he was in behavioral therapy, that wasn't happening. And so now he has been seeing a mental health therapist for many years. And one of the issues was they didn't presume competence. And so they treated him like an animal. And so really just the value of creating a safe relationship with that person and co-regulating with them when they start to feel distressed, I think is so powerful.
Yes. And if I may, and this is why I'm so glad, Amy, that you spoke up as well. I never want to seem as if I'm minimizing some of the challenges of figuring out how someone best receives that or how they best communicate. Or, yeah, we're going to talk about, I remember one young man on the spectrum, and we talked about fans. That was his thing, like room fans, like, right? And we talked a lot about fans. So I never want to suggest that that's a simple, easy process, but I will say the heart of therapeutic toolkits, I should be figuring out how to reach someone, and whether that's a longer path for somebody than someone else really is beside the point. So when you talk about relationship is the most important vehicle for him, I have to tell you, Jenny, my first thought was, yeah, me too. And that's, again, not to minimize the challenges for your son. It's just to say, yes, that's how human beings are built, right? The ability of the brain to connect to another human being develops long before the executive function, abstract reasoning brain. So it's also the heart of trauma. When we think about trauma, it is sometimes called an injury to the ability to relate whether that's to the self or to others. So I'm so grateful that you were able to find that. I wish there were more. I think the mental health field is gradually catching on, that we can work much more effectively with some folks that previously we thought we couldn't. Unfortunately, it also means that, I think, Amy, this is probably your experience as well, that you've got to be a fierce advocate, and maybe you're the person sitting down with a therapist to say, here's some ideas and some, insider information about how to reach my kid, but what my kid needs is exactly what every trauma survivor needs, and that is a healing of the relationship to self and a healing of the relationship to other human beings. It is exactly the same. So, again, not to overstep your experience or anything like that, but I think what you guys are both talking about is so important.
Thank you so much, Laura, and thank you everyone that attended today. We did record this. We're trying to figure out where we're going to post it and where it'll live so that those that were not able to join us today can watch it. And so, yes, if you have coworkers, if you have other people that that wanted to see this today, please let them know. We will have this recorded and posted at some point here in the near future. And yeah, thank you all so much for attending.
Great. Thank you, guys. Thank you, Jessica. And yeah, thank you so much.
Thank you.
Thank you.
Thanks.